Good afternoon. We shall be dealing with case number 2 in our ECG series. The title of this presentation is Never Miss the Forest for the Trees. So this is a title I've taken from Balance Syndrome's description, in which is characterized by visual inattention. You give a patient the picture of a forest, he will focus on the individual trees rather than the forest. So why I've chosen this title, I shall explain at the end of the video. So we shall go straight to the case. 38-year-old female with no prior comorbidities, brought to the ER in a drowsy state, with no prior history of seizures. On examination, she is spontaneously moving all four limbs. Bilateral pupils are equal and reacting to light. Heart rate is 58 per minute. She has bounding pulses and blood pressure is 190 by 120 millimeters. She is markedly dyspneic. Chest shows bilateral fine crepitations with a saturation of 84%. Her blood sugar is 120 milligrams per deciliter. So to summarize, you have a young female who has no comorbidities, brought in a drowsy state with bradycardia, hypertension, and what looks to be pulmonary edema, and she is fairly euglycemic. So this is her ECG which is taken. So you can analyze this ECG, and based on this, what would you do? So A, you can give aspirin, clopidogrel, and atorvastatin loading dose. B, you can give heparin along with the above loading dose. C is you can thrombolyze the patient. 4 is you can start on blood pressure lowering IV medications. 5 is you can order TROP-T and wait for the result. And 6 is do a CT brain. So you can pause the video if required, or you can just continue on. So the first thing you would assess, is it cardiac or non-cardiac? That's the first thing you would assess. So if it's purely a cardiac cause, there are certain confounding factors. One is the age and sex of the patient. Have a female in the reproductive age group to have an ACS is pretty rare, unless the patient is diabetes or she has a strong family history. It's not always a rule, but it's a general guideline. 2 is a drowsy patient. Now, drowsiness is extremely uncommon in a purely cardiac pathology. And 3 is you have bradycardia. Now, usually when the patient has pulmonary edema, you have tachycardia, heart rate is say 120, 130, and you have rapid thready pulses. And as the patient stabilizes, your heart rate comes down. So bradycardia and bounding pulses in a diagnosis of a cardiac pulmonary edema usually goes against it. So the ECG shows giant T inversions. You can see here, T inversions in the chest leads. In some cases, leads are exceeding 15 millimeters with a markedly prolonged QT interval. Now, as a rough guideline, if you want to see a QT interval very quickly, what you can do is you can take a midpoint of between two RRs, and if the T wave crosses this, it generally indicates a prolonged QT interval. Now you can see in this case, it's clearly a prolonged QT interval with giant T inversions. Now let's go to the options. What will you do? Give aspirin, clopidogrel, atorvastatin, and loading dose. As I said, the diagnosis, we have several confounding factors going against the diagnosis of cardiac pulmonary edema. So it would not be prudent to give aspirin, clopidogrel, atorvastatin in this case. Again, for the same indications, giving heparin also would not be good. Same would be to thrombolyze the patient. And again, starting on blood pressure to lowering IV medications. Now, the patient being drowsy would consider a CNS cause, and hypertension may be a compensatory reflex to maintain cerebral perfusion. So it would not be wise to reduce the blood pressure. Ordering troponin and waiting for the result again would do no harm, but the immediate management would be to do a CT brain. We need to find out what's going on. Why is the patient drowsy? So the CT brain was done, and you can see a large subarachnoid hemorrhage. You can see the sulci and gyri are filled with blood, and you can see the temporal horn of the lateral ventricle is prominent. In a young person, it indicates probably obstructive hydrocephalus. So you have a subarachnoid hemorrhage with obstructive hydrocephalus. Now just imagine if you had lysed this patient or given heparin or DAPT, it may have been fatal for this given patient. This is the X-ray which shows pulmonary edema with a normal sized heart. So the most important message I would like you to take from this presentation is this. In a purely cardiac cause of pulmonary edema, there should be no impairment in sensorium. In fact, patients are anxious and agitated. Even a minimal impairment in sensorium suggests a coexistent alternative pathology, the most common being uremia or hypoglycemia. So in a pulmonary edema of purely cardiac cause, the sensorium should be perfectly normal. There should not even be a minimal deterioration of sensorium. If so, you consider an alternative pathology. In this case, the most common being uremia and hypoglycemia. In this case, the patient probably had a neurogenic pulmonary edema, which is well known to occur in subarachnoid hemorrhage. So how do you classify T inversions? So a mild T inversion you have is between zero point 0.1 to zero point 0.5 millivolt. Deep T inversions are between zero point 0.5 to 1 millivolt, and giant T inversions, as in this case, are greater than 1 millivolt or 10 small boxes. So what are the differential diagnosis of giant T inversions? The most common cause would be coronary ischemia. So you can see a giant T inversions across the chest leads. The first thing you think about, especially in a background of chest pain, is that the patient has some degree of coronary ischemia. Now, it is not indicative of the severity of coronary ischemia. You cannot say a giant T inversions indicates a very severe coronary artery disease, and smaller T inversions indicate that the patient has less significant coronary artery disease. So it just indicates coronary ischemia. 2 is cerebral T waves, as in this condition. 3 is hypertrophic cardiomyopathy, especially apical HCM. 4 is post-Stoke Adams attack. Now, when a patient recovers from a Stoke Adams attack, you can have giant T inversions. And last is Takotsubo cardiomyopathy, because Takotsubo cardiomyopathy and cerebral T waves basically share the same mechanism, which is sympathetic excess. So, what are the ECG changes in CNS disease? So the most common underlying cause, CNS condition which causes ECG changes, is subarachnoid hemorrhage, which is closely followed by intracranial hemorrhage. It has also been reported in a variety of conditions like intracranial tumors, ischemic stroke, especially middle cerebral artery infarcts, TIAs, traumatic brain injuries and seizures. Usually the underlying pathology is elevated intracranial pressures. The most common region of the brain affected is the Sylvian fissure or the insular cortex. The most common part of the ECG involved is repolarization. Now, repolarization is the critical part. When you compare depolarization and repolarization is far more susceptible towards changes. The most common change you look for is sinus bradycardia. Again, sinus bradycardia occurs as part of the Cushing's reflex. When the intracranial pressure increases, you can have sinus bradycardia, hypertension, and respiratory changes. So the most common change is sinus bradycardia. What are the other ECG changes? You can have ST depression. You can have ST elevation, so that it might actually mimic an MI. T inversions, QT prolongations. You can have malignant ventricular arrhythmias like VT, Tossard, and VF, especially when your QT prolongation, when the QT is prolonged. You can have increased height of the R waves, so you might think that the patient has LVH. You can also have large U waves, so sometimes you might think the patient has hypokalemia, especially when the QT is also prolonged. So this is a study from 1987. We showed what are the commonest STT changes in SAH. Most common are large U waves, which are just closely, which is followed by a prolonged QT, which is again followed by tall R waves. Again, you can have ST depression and other T wave abnormalities. So this is another example, an 18-year-old with severe traumatic brain injury. You can see diffuse ST elevation in all leads except AVR and V1, which mimics a pericarditis. Again, ST elevation is also common, so you must keep the appropriate clinical background in mind. So what is the mechanism? Two main mechanisms are hypothalamic stimulation and autonomic dysregulation. Basically, you have a catecholamine excess. So the same pathology is shared in Takotsubo cardiomyopathy also. A catecholaminergic surge which occurs stimulates beta receptors, which causes the calcium channels to be in a persistently open state. This causes prolonged depolarization without repolarization occurring. And this causes cardiac muscle cell death. So you have basically a prolonged depolarization without repolarization causing cell death. And the ECG changes frequently resolve with a decrease in intracranial pressures. So why is this important? In such a scenario, antiplatelets, thrombolytics, heparin are usually contraindicated and may be fatal if given to the patient. Just imagine you have a large intracranial hemorrhage or a large subarachnoid hemorrhage and you thrombolize the patient or give heparin. 2 is unnecessary activation of the cath lab. Now, in these days of primary PCI, the patient is taken to the cath lab, you do an angio, you find normal coronaries, and later you find the patient is not waking up. You do a CT brain and you find underlying CNS pathology. Now remember, even while doing an angio, you give heparin. which can also be fatal for such a patient. Now, if you're working in large hospitals which do organ transplants, ECG changes may cause a rejection of the donor. So you must keep this also in the back of your mind that the heart may be perfectly normal and this might be a response to underlying CNS pathologies. So what is the learning points you can learn from this case? So the most important is a minimal impairment of sensorium in pulmonary edema should be viewed very seriously. Cardiac pulmonary edema, patients are hyper alert. So even a minimal impairment of sensorium, think of some other coexistent cause, the most common being CKD and hypoglycemia. Two is ECG changes are common in CNS conditions, sometimes frightening. And you should keep that in the back of your mind, especially when the patient has some CNS localizing signs. CT prior to antiplatelets, heparins, and lytics may be life-saving in the given scenario. Last is treat the patient, not the ECG. Hence, I shall explain the title of this, Never Miss the Forest for the Trees. You had so many points against a routine diagnosis of cardiac pulmonary edema and possible ACS. So you had to see the patient as a whole, always treat the patient as a whole and never look at only the ECG or in fact any investigation in isolation. So thank you. So please like, share and subscribe and press the bell icon for further notifications.